Test, test, test. Test, test. Test, test. Jadi, saya petik jari soundnya. Boleh start. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh, and a very good morning to our honorable guest, Dr. Tengku Anas Fathi bin Tengku Ahmad, Deputy Hospital Director, and all heads of departments, specialists, and the rest of HRPZ staff. First and foremost, I would like to thank you everyone for allocating time listening to the CME today. I am Muhammad Amin bin Muhammad Nordin from Medical Department, will be your MC for today. Before we start our CME today, I would like to give few announcements. Kindly scan QR code on the screen for attendance, and the QR code link has been provided in YouTube comment section. Any question can ask at chat box at YouTube link. And then we are very fortunate today to have Dr. Huwaina binti Abdul Sattar, pakar ophthalmology, UD 52, to be to act as a presenter for our CME topic today, retinopathy of premature, fighting blindness in premature. Without further ado, I would like to invite Dr. Huwaina.
Assalamualaikum and a very good morning to Dr. Muhammad. Thank you to Dr. Muhammad, Dr. Tunku Anas, all the HODs and also specialists and all the audience. I'm Dr. Huwaina Abdul Sattar from Ophthalmology Department. Today we'll be present about retinopathy of prematurity, fighting blindness in prematures. Okay, this is my outline of presentation today. Okay, what is ROP? Okay, ROP is retinopathy of prematurity. Is vasoproliferative retinal disorder of vasoproliferative of retinopathy of prematurity is a vasoproliferative retinal disorder of low birth weight premature infants. So the spectrum of this disorder, it can be mild, self-limiting with no visual defect, or it may become aggressive with neovascularization and progress to retinal detachment and blindness. So the stimulus for the abnormal growth of blood vessels, it's come from the peripheral immature retina of premature. And early detection and effective management of this condition can prevent blindness. Okay, this is normal retinal angiogenesis. Just a quick review. The retinal blood vessel grows from the optic nerve head. It traverses the inner retina at about 16 weeks of gestation. And then it will transverse and reach the nasal peripheral retina at about 36-week gestational age. And it will reach the temporal peripheral retina at about 40-week gestational age. So what happened in premature? There is incomplete vascularization and also immature peripheral retina at birth. This diagram, this picture shows that there is incomplete vascularization and also immature retina, peripheral retina of the premature. And there is the stimulus for the abnormal growth of blood vessel that come from this peripheral immature retina. So this picture shows this fundus photo of a premature infant that shows this is a peripheral immature retina, and then this is vascularized retina. Okay, what happens in ROP? Actually, the pathogenesis of ROP, it have divided into two phases, which is the phase 1, vaso-obliterative phase, and also phase 2, vaso-obliterative phase and vasoproliferative phase. Okay, what happened in vaso-obliterative phase? Usually, vaso-obliterative phase occur at 22 to 32 weeks of gestational age. At this stage, usually hyperoxic phase. This hyperoxic phase, the excessive oxygen will suppress the vascular endothelial growth factor. And this suppression of vascular endothelial growth factor will inhibit the normal vessel growth. Then, what happened? In the vasoproliferative phase. Usually, vasoproliferative phase occur at 32 to 34 week gestation. There is relative retinal hypoxia. This relative retinal hypoxia will cause the overexpression of the angiogenetic factor of vasoendothelial growth factor. This overexpression of vasoendothelial growth factor will cause precipitate retinal neovascularization. Okay, in the pathogenesis of ROP, actually there is the oxygen regulated factor, the vascular endothelial growth factor, is not the solely factor that causes the ROP. There is another factor, we call it as non-oxygen regulated factor. We call it as insulin-like growth factor. This insulin-like growth factor, the low level of insulin-like growth factor will prevent the normal vessel growth, but in higher level also will cause the neovascularization. Okay, this fundus photo showing of what happened in vaso-obliterative phase that usually occur at 22 to 30 weeks gestation. This is this fundus photo showing of the vascularized retina, and this is a peripheral immature retina. Usually, we can detect of the demarcation line or ridge at this stage. What sign that we can see during the vasoproliferative phase that usually occur at 32 to 34 weeks? Okay, this fundus photo showing of neovascularization or that occur at the vasoproliferative phase. Okay, then we go to the risk factors of ROP. Okay, actually the first three of risk factor is the most important risk factor for developing ROP, which is the low birth weight less than 1,500 grams, prematurity less than 32 weeks, and the supplemental oxygen. The supplemental oxygen, there is few studies shows that the repeated hyperoxic and hypoxic state that will contribute to the formation of ROP, and the strict management of oxygen fluctuation will reduce the ROP occurrence. The other important risk factor for ROP such as intraventricular hemorrhage, sepsis, surfactant anemia of prematurity, and the others that mentioned below. Now we go to classification of retinopathy of prematurity. So based on international classification of ROP, ICROP 1984, and it revised on 2005, and the latest one of ICROP of 2021. It classifies the ROP according to the location of the disease into 3 zones, the severity of the disease into stage, the extent of the disease based on the clock hours, and the presence of plus or pre-plus disease. However, there are another classification of ROP. We call it as APROP or aggressive posterior retinopathy of prematurity. Okay, this is the location, how we locate the zone in ROP. Actually, zone in ROP only an imaginary zone. It's not a true zone that we see in the fundus of the baby. So zone 1, actually it extends from the optic disc to a point that double the distance of optic disc to the fovea, meaning that easier way to remember is actually the distance is 2 times the distance between the optic disc to the fovea. What is zone 2? Actually, zone 2 is a circle that surround the zone 1 with the nasal retina, with the nasal aura as a nasal border. And zone 3 is the residual crescent that anterior to the zone 2. Okay, this is a fundus photo that showing the zone in fundus when we see the fundus of the premature baby. Actually, it's not a true line, only the imaginary line. Okay, the stage of ROP, we can divide into stage 1 to stage 5. Where the stage 1, actually the formation of the demarcation line. The demarcation line actually they separate the fundus into the vascular retina and also the avascular retina. The demarcation line we can see at the border between the vascular retina and also avascular retina. And at stage 2, when the demarcation line is widened and it thickens, so it forming ridge. And then if progress to stage 3, we call it when there is a neovascularization of the overlying the ridge. And then at stage 4, when there is already subtotal retinal detachment. At stage 4, actually we can divide into stage 4A or 4B. 4A, when it's subtotal retina but not involving the fovea, but in 4B, when it involves the fovea. And stage 5, already total retinal detachment, also divided into 5A and also 5B. 5A is open funnel and also 5B is closed funnel. So we go to extent of ROP. The extent of ROP is recorded as clock hours in each eye according to the relevant zone. So, for example, this ROP occur at zone 2 from 1 o'clock to 6 o'clock. So it is a 5 contiguous clock hours. For example, at this ROP occur at zone 2, but 8 cumulative clock hours. Okay, what is plus? Plus is actually the indication of activity of the disease. It's characterized by the dilatation and also tortuosity of the retinal vessel, iris vascular engorgement, poor pupillary dilatation, and also vitreous haze. Just now I called about the APROP or aggressive posterior retinopathy of prematurity. Actually, this ROP is a distinct variant of ROP stage. It can rapidly lead to blindness in extremely premature and low birth weight infant. It's characterized by severe plus, flat neovascularization in zone 1 and posterior zone 2, and it rapid progression to retinal detachment. Despite early laser photocoagulation, favorable outcome rates for APROP vary from 71 to 84. Actually, the APROP is posterior disease. It's usually at zone 1 or actually at the posterior zone 2. Okay, these signs showing of ROP with prominent plus disease with dilatation and tortuosity of the vessel. The stage 3, neovascularization at zone 1 and neovascularization at posterior zone 1, at zone 1 and posterior zone 2. Okay, now we proceed to our case presentation. Okay, case 1, baby of NZS, which is a prem 34-week with birth weight of 1.87 kilogram. The risk factors of RTS and sepsis. Initial review at 35 and 38 weeks revealed there is no ROP bilateral eye. However, at 40 weeks review, noted to have bilateral eye stage 2, zone 2 ROP with the formation of ridge at the zone 2. Subsequently, we reviewed this baby at 43 and 46, still stage 2, zone 2, not progress. And at 48, subsequent review at 48, 51, 54 weeks, showing of regressing from the stage 1 to, from the stage 2 to stage 1 at zone 2. And subsequent review at 58 weeks, noted that regress ROP of stage 1 fully regressed and the vessel is fully vascularized up to zone 3. Showing this case actually showing that not all the ROP is can progress to further stage. It also one of the spectrum of the disease, actually it's self-limiting, and also it's can self-limiting and not worsening lah. However, the monitoring is important until we see that the ROP truly regress. Okay, this is the reach. Okay, case 2, baby of TCM, premature 25 week with birth weight of 800 grams. The underlying issue or risk factor for this baby is ventilatory dependent until day 112. Severe RDS with bilateral intraventricular hemorrhage grade 2, anemia of prematurity, and sepsis with recurrent pneumonia. Initial review at 35 weeks noted bilateral eye, no ROP. However, at 37 weeks, showing a slight progress to stage 1 zone 2 ROP. And at 38 weeks, unfortunately, it further progressed to bilateral eye stage 3 zone 2 with no plus. Remember just now the stage 3, actually the formation of neovascularization. At this stage, we proceed this baby with the bilateral eye laser, indirect ophthalmoscope, LIO. Okay, this picture showing the setting during the laser indirect ophthalmoscope done at the bedside. This fundus photo showing of pre-LIO, the formation of neovascularization stage 3, and post-LIO, the formation of a laser mark at the peripheral immature retina. Then follow up of that case just now at 40 weeks, showing of regressing ROP, and further review at 42, 44 until 50 weeks at 6 months of age, noted ROP regress, totally regress. And further review TCA during 7 months, regress ROP with laser mark retina flat, no formation of any retinal detachment. At 9 months and 1 year, we do cyclorefraction just to monitor if there are any complication of ROP in complication of ROP such as myopia. Okay. Then we proceed with case 3. Case 3 is a case of APROP, aggressive posterior retinopathy of prematurity. Actually, this case is referred from Hospital Tanah Merah, baby of NAS. It's a prem 31 weeks plus 6 days with birth weight of 1.8 kilo. Ventilated for 15 hours with underlying mild RPS and intraventricular hemorrhage. However, we have limited information regarding this baby as it's not stated in the referral letter what happened during the initial presentation. We first review this baby at 35 weeks plus 4 days, showing already bilateral eye posterior ROP zone 1 with tortuous and dilated vessels. Actually, the formation of new vessel actually already at zone 1. So our impression is bilateral eye aggressive posterior ROP, and then we proceed this baby with intravitreal antivascular endothelial growth factor or ranibizumab in the OT setting under general anesthesia. Okay, this picture showing the preparation in the OT setting for the intravitreal anti-VEGF baby under general anesthesia. This is the procedure. During the procedure, Okay, the injection of intravitreal into bilateral eye. Okay, thank you, courtesy for this picture for our vitreoretina team, NS team, and also a pediatric team. Then we proceed with the case 4. Case 4 also referred from Hospital Tanah Merah. It's a prem 26 week with birth weight of 800 gram. First review, initial review at 34 to 35 weeks, already stage 1 at right eye, and left eye stage 2, zone 2. And subsequent review at 36, 37 week, it further progressed to stage 2, zone 2. And at 38 weeks, it further progress into stage 3, zone 2 with plus disease. At this level, we proceed with laser indirect ophthalmoscope. However, post procedure, post LIO, at 40-week review, noted to have pre-retinal hemorrhage. However, this is laser-related retinal hemorrhage complication of laser. And then subsequent review of 41, 44, showing of regressing ROP. However, at 47 week, right eye started to have a fibrosis at temporal and left eye fibrosis at nasal. However, the subsequent review at 49 to 50 weeks noted similar finding with not progress. Unfortunately, at 51 week, it progressed further to stage 4, which is partial subtotal retinal detachment. However, at left eye, still stage 3, showing of regressing sign. So for the right eye, we proceed with the scleral buckle under GA. Actually, this scleral buckle is surgical management of retinal detachment. Okay, post-operatively, we review at 52 to 54 weeks. The right eye stage 4 showing of foveal dragging with elevated retina peripherally, and left eye stage 3 with fibrosis. At 57 weeks, bilateral eye stage 4 showing progress, which is the retina is detached peripherally of both eye. So we proceed with the left scleral buckle, and for the right eye, we tighten the initial scleral buckle. However, this baby was continue the follow-up in Hospital Kuala Lumpur as due to logistic reason. Okay. This fundus photo showing of peripheral retinal detachment. Okay. So now we go to a screening of ROP. Who should be screened? Actually, the premature at less than 1,500 gram and born at less than 32 weeks of gestational age. However, in selected infant that the weight is between the 1,500 to 2,000 gram, and gestational age is more than 32, with unstable clinical cause, we still screen. This selected infant actually by a pediatrician or neonatologist reference lah. And when to start screen? Actually, the median age of ROP occur at 37 weeks, and 90% of ROP actually occur between 34 to 42 weeks. Therefore, start screening at 34 weeks, or alternatively, we can start screening 4 weeks postnatally. So the follow-up interval for infant that risk, actually if a baby during the initial screening, no ROP, no sign of ROP, so we should screen at 2 to 3 weeks interval until the retina is fully vascularized. If ROP is present, if present at zone 1, at any stage, but without plus, so we screen at least weekly. But in zone 2, at stage 1, we should screen 2 weekly. In zone 2, stage 2, without plus, we screen at 1 to 2 weekly. And if zone 2, stage 3, without plus, we screen at least weekly. This algorithm that explains the how we screen the premature, like I explained just now. Why screening too early is not advisable? Because when the infant are born at 27 weeks, and fundus examination is performed at before 30 weeks of gestational age, actually often impossible to assess the retinal status because of the cornea clouding, also the presence of remnant of tunica vasculosa lentis, which is the problem of media from the cornea and also the vitreous. The eyelid separation process begin at 20 weeks of gestational age, and most infants can blink at 31 weeks. Thus, good retinal image can be obtained after the eyelid are able to open spontaneously and the corneal moisture has dried properly. Therefore, it is suggested that the first eye examination be performed after 31 weeks. Okay. So we go to management. Actually, the indication for treatment indication for treatment can be divided into two at the threshold ROP when there is a stage 3 zone 1 or zone 2, the presence of 5 or more contiguous clock hours or 8 cumulative clock hours with the presence of plus, or in the group of high risk pre-threshold at zone 1 at any stage with plus, zone 1 with stage 3 without plus, and zone 2 at stage 2 to 3 with plus. Okay. The type of treatment, according to ETROP study, laser therapy. The second is cryotherapy. Actually, this cryotherapy is the first type of treatment that started at 1984 actually, but now no longer used due to the laser is superior in the therapy of ROP, and also it's associated with high procedure related complication, either ocular or also systemic. For vitreoretinal surgery, scleral buckle, we do a stage ROP stage 4B of 5, or lens sparing vitreous surgery. For the disorganized anterior segment, less aspiration in an advanced cicatricial ROP with shallow or flat SE. And the last one is anti-vascular endothelial growth factor. Okay, this algorithm explains the treatment option in retinopathy of prematurity. It depends on the severity of the ROP. Okay, at the threshold and high risk pre-threshold, usually we do laser. At stage 4, 5, either scleral buckle or vitrectomy. Okay, this is a few studies that related to ROP. This is a cryo ROP, the first initial study done at 1988. Then proceed with the ETROP, that is study about the laser versus observation, and the result showing that reduction of unfavorable outcome at 6 months from 10% in observation group to 4.9% in laser group. So it recommends that laser treatment in the type 1 ROP. And for BEAT ROP and also Rainbow, actually for the anti-VEGF, vascular endothelial growth factor. However, BEAT ROP, it's a study on the bevacizumab. However, it's off-label, not used. And for the Rainbow, it's ranibizumab, a study of 0.2 milligram versus 0.1 versus laser photocoagulation. Okay, the results showing of absence of active ROP and unfavorable structure outcome that increased from 62 in laser group to 75 in ranibizumab 0.1 and 80% at ranibizumab 0.2. Okay, just a quick review on the treatment of ROP. First is laser in ROP, laser indirect ophthalmoscope. The principle of treatment, actually, we want to remove the stimulus for the growth of new vessel, new blood vessel by ablate the peripheral avascular retina, because the peripheral immature retina will produce the stimulus for the new vessel growth. Ideally, we do at 2 to 3 days of diagnosis, either in general anesthesia, sedation, at bedside or OT setting. Its advantage over cryo, actually it's less post-treatment complication, and also reduce the systemic complication that can happen during cryotherapy, such as bradycardia, cyanosis, and apnea. The complication of laser, corneal burn, cataract, and also retinal and vitreous hemorrhage post-treatment. This picture showing of the laser mark at the peripheral immature retina. This is signs how we see there is how we see the ROP is regressed. When the media is clear, the pupil can fully dilate. No new iris or retinal neovascularization, or retina or pre-retinal or vitreous hemorrhage clear up, and regression of the plus, and also the regression of other signs such as demarcation, ridge, or all the signs that I mentioned previously. So cryo, actually it used the extreme cool to freeze the targeted tissue. It significantly improved the outcome of severe ROP. However, it's a higher incidence of treatment-related complication. So it rarely used nowadays. And antivascular endothelial growth factor. It is a humanized monoclonal antibody that inhibits all the VEGF-A isoform. Actually, it's a first-line treatment in APROP and also zone 1 disease, according to Means et al. Anti-VEGF in zone 1 in APROP showed good anatomical outcome. The advantage of anti-VEGF is if compared to the laser, it can preserve the peripheral visual field, and it can allow the vascularization till peripheral compared to laser therapy, and less likely to develop myopia. Okay, the sclerobuckle, actually the surgical management of retinal detachment, usually done for stage 4 or 5 ROP, and the success rate for sclerobuckle for stage 4 is 66 to 70% for stage 4A and 67% for stage 4B. Actually, it's placing a flexible silicone band around the circumference of the eye, and this band will force the retina to remain in place. This is the silicone band. Actually, will place in the eye to force the retina to remain in place to treat the retinal detachment. This is few complications of ROP that we have to look for during our follow-up, which is first is myopia. 80% of infants with ROP related with myopia. Strabismus and amblyopia, the prevalence is about 23 to 47%. Retinal detachment, 22% in ROP, and acute angle closure seen in cicatricial ROP. Okay, the strabismus. Okay, the follow-up wise for the baby with ROP depends. If baby is treated for ROP, we follow up him till it reach preschool age, yearly till it. Then during the follow-up, we must do the cyclorefraction. We monitor for the fundus, and also for the any presence of squint in the baby. For children with threshold ROP, if the threshold ROP is adequately lasered, given and show a regress, so we follow up at 3 months. And then at 6 months, we do cycloplegic refraction, and more frequent follow-up is indicated. However, in unfortunate children with complicated ROP, so need for the social and educational support for these children. long-term follow-up, what we see during follow-up for the visual development, visual acuity, the refractive status, presence of any strabismus, or the presence of anisometropy amblyopia, or any retinal and lens status. Okay. So our take-home message, actually screening of premature infant that at risk with appropriate timing of examination and also follow-up, actually important to early identify the treatment that need for the treatment. However, in our ophthalmology setting, the challenges during assessment with limited view, with the baby in the incubator, with the unstable clinical condition, with poor pupillary dilatation, actually it's quite challenging, because usually baby with unstable clinical condition, it's difficult to examine. Then until at this stage that we can review, baby already have the changes, all the ROP changes. Actually, this ROP is a treatable disease and also preventable if we can detect early. And then important is we co-management with the neonatal team. Okay, this is my reference. Okay, for that, I thank you.
Thank you, Dr. Huaina, for such a splendid presentation just now. So now we are into the Q&A session. Is there any question from the floor or any question from online attendance? Kindly ask in the YouTube live chat box. Okay.
We have a question actually. What's the question? What's the outcome of the case 3 and case 4?
Yes.
Right. Okay. Actually, the case 3 is just a new referral, a new case that we just see about 2 weeks. 2 weeks, last 2 weeks. So the intravitreal antivascular endothelial growth factor, the anti-VEGF that we just gave last Thursday. So we still monitor this baby, cannot monitor for the vision yet. For the case 4, actually, is the last review was on November last year, and then the father request for further follow up at Hospital Kuala Lumpur due to logistic reason.
Okay, with that, if there's no more question from the online attendance and attendance from the floor, I would like to invite the Tengku Anas to give a certificate of appreciation to Dr.
Okay, gracias.
Okay. With that, we end our CME for today's session. And for the CME next week will be next 2 weeks. Next 2 weeks will be under medical team, under respiratory team. The topic will be announced later. Okay, thank you.